Hello and welcome to the Mini Battles e-series by Athens Soldier Course. My name is Manos Brilakis and I am the head of the organizing committee of this course that unfortunately has been cancelled this year due to the pandemic. However, being driven by our passion for continuous education and communication with our international friends, we came up with the idea of launching these monthly webinars dedicated to shoulder pathology and treatment, the Mini Battles e-series. Thus, we count down until the next Athens Shoulder course, hoping that next February we'll be able to welcome you again live in Athens.
Hello, and from me, let me welcome you also. I'm Manos Antonogiannakis. I'm the chairman of Athens Shoulder Course, and as already Manos told, we had to cancel due to the situation with the COVID this year. We had to cancel the course, but still we thought that we could continue our discussions with our international friends, and every month we have a discussion with two charismatic surgeons about an interesting shoulder topic.
Today is the episode number 11, and the subject is the use of model anchors or anchorless techniques for rotator cuff repairs. Before introducing our guest, please take a moment to vote the following question. What is your preferred fixation choice for a rotator cuff repair is the question, and the options is suture anchors, knotless anchors, vented anchors, or transosseous repair. Please take your time and give us your answer.
For this episode, we are going to discuss a very interesting topic of rotator cuff repairs, and we have two surgeons with us. It's Dr. Brett Sanders. He's from USA, and he's from the Center of Sports Medicine in Chattanooga. And also Nuno Gomes, the vice president of ESA from Portugal. And we are going to discuss the issue of newer techniques of stabilizing the cuff and also enhancing the biology of the repair.
So throughout the mini battle, you can also submit your question, and without further delay, let's the mini battle begin.
Okay. I heard the bell ring, so I guess that means we're starting. I'm Dr. Brett Sanders from Chattanooga, Tennessee. Thank you so much for the invitation to speak to you today about a topic that's very dear to my heart, modern arthroscopic transosseous rotator cuff repair. And I'm going to show you some alternatives to anchor-based repair. I do have a relevant disclosure. I founded a company that makes a reusable transosseous tunneling device. We all know that transosseous cuff repair has been the gold standard throughout history, but there's some modern facets of transosseous that are interesting to discuss that I'd like to update you on regarding cost, biology, biomechanics, pain, revision considerations, outcomes, and other synergies that we can use newer techniques with other pre-existing fixators. I became interested in this 15 years ago with Dr. Warner at Mass General when value-based medicine was coming out, and the Harvard Business School defined value as outcome over cost per episode. In the United States, bundled payments, and in Europe, single-payer systems have been putting cost pressure on care, making it difficult for providers. Simultaneously, there's been technological convergence and commoditization of technologies so that one anchor and another anchor are essentially the same. We know that Transosseous has non-inferior, at least non-inferior, possibly equivalent or superior outcomes, and the cost effectiveness is exceptional, offering superior value. Dr. Codman, who is the founder or the father of value-based medicine and evidence-based medicine, was measuring cost of rotator cuffs 100 years ago. The concept of the rotator cuff repair cycle bears mentioning, because where are we coming from? We need to understand where we came from. This transosseous cerclage effect is what we're chasing. That's what we're after. That's the best way to recapitulate the anatomy of the tendon. And we've moved to doing this open and then mini open with anchors. And again, much of this was driven by industry and biomechanics more than outcomes, cost, or biology. When the anchors were adopted arthroscopically, the outcomes became much worse. And the single row tendon anatomy was very poor. It took about 10 years to catch back up with double row transosseous equivalent constructs, adding a lot of cost and adding an anchor-specific failure mode, which transects the tendon. I've done some work on hybrid techniques, which I'll show you, to try to step surgeons into fully transosseous arthroscopic techniques so that we can use the best of both worlds. But eventually, I think we need to get back to where we came from. What is the ideal repair? Well, we learned from Christian Gerber years ago, high initial fixation strength to resist ultimate and cyclic failure, prevent gap formation and shear forces. And I think we're doing that with these repairs. We want to reproduce the anatomy and avoid bird beak and dog ear deformities, which have to do with the number of fixation points. Reusable transosseous tunneling gives you unlimited fixation points within a case. We want to avoid these large bone voids that anchors create and the specific stress riser of the medial row, which leads to type 2 failure, which is a catastrophic failure mode. Of course, we want excellent outcomes, as shown by Dr. Shukumaran here, with ultrasound follow-up showing no difference in transosseous versus anchor-based repairs. But I'd like to introduce some new ideals. Perhaps we should be looking at the biology of the tendon on MRI and how well they heal. You can see the excellent healing of these tendons, and sometimes the radiologist will read them as negative. They can't even tell they've been repaired. We want to be able to use our biologics and our patches and introduce newer technologies under a cost ceiling. And we need to be mindful of blood flow. All of these repairs need blood flow. And you can see in figure B and C in this paper, the transosseous blood flow is vastly superior. There's also different biomechanics. We avoid this stress riser and we mitigate the stress gradient coming across this repair site. We can also introduce concepts such as load sharing with multiple fixation points and high fixation point per surface area, as well as synergize with existing technologies like in this true transosseous hybrid using one anchor that I'll show you later. Dr. Lazarus has shown us as well that we have time equivalence in the OR with transosseous techniques, and we have superior cost reduction. Now, industry's answer to this problem of transosseous cerclage effect has been the transosseous equivalent, and it's right there in the name. And the paper states they're trying to recreate what transosseous cerclage effect does already. And interestingly, they thought you only needed about 300 newtons of force, which is the theoretical maximum supraspinatus contraction. In their papers, they list lower profile knots and not relying on the torn edge of the tendon as advantages. Transosseous can achieve this. Reduce surgical time, which I've shown you transosseous can achieve as well. And importantly, placing anchors in the healing zone reduces potential for area of healing. I totally agree with the anchor surgeons there. And I'll show you some load sharing constructs. And essentially, all of these advantages can be achieved transosseously, but at less cost. Biomechanically, this was one of my first constructs. Hybrids have been out there with anchors and tunnels used together, 400 newtons of failure for this one. Essentially, a cuff repair is an optimization problem, and the surgeon has to decide, are they going to focus on time, quality, cost, hardware, usability, and there's a lot of different options that the surgeon has to decide. This is Brian Cole's slide on the right showing that anchor-based repairs have about 350 to 400 newtons of strength. And I'd like to call your attention to this paper, which does not get a lot of publication. This is Gus Mazzacca, Bernie Bach, known researchers. With all suture, they were getting 856 newtons of ultimate failure. They were ripping the surgical neck off with only suture. And so now that we can do this arthroscopically with unlimited fixation points, I think that is within striking distance clinically. I'm not going to go into the entire biomechanics argument, but I will tell you that the stress risers and the stress gradient is reduced. It's a different type of biomechanics. It's not all about ultimate failure strength at time zero in a cadaver, which is what we've been sold anchors on in the past. Scott Rodeo and Uma Shukumaran have both shown that it's all about the sutures and number of sutures crossing the repair site. Everyone was talking about single versus double row repairs, and nobody controlled for the number of sutures. So I would urge attendees and academics in attendance to start thinking about fixation points instead of rows. I think rows is outdated anchor-based terminology, and we should think about fixation points per surface area and numbers of sutures per fixation point as our strength metric. This is a novel construct I wrote up in Arthroscopy Techniques called the True Transosseous Hybrid, which is meant to use the best of both worlds. And the advantage is there's no anchor burden at the footprint for better revision considerations and no inert hardware in the healing zone. It's triple row if you care about rows, but there's independent fixation. So the transosseous repair is independent of the anchor repair. You're not relying on the knotless anchor if it pulls through. There's cortical augmentation if you believe the bone is weak, and there's a second chance at knotless tensioning of the entire construct. In addition, it's improved cost for multiple fixation points, and it's a self-reinforcing construct. And this is what it looks like arthroscopically. You would think there's multiple anchors in there. There's only one anchor being used in these constructs. The rest are transosseous fixation points. This is my pilot study on this technique, 143 patients with 14-month follow-up. We had a 4% re-tear and a mean ASES score of 92, very high. While we're on the topic of outcomes, I will show you as well, Dr. Shrikumaran has shown with ultrasound 2-year follow-up, no difference in transosseous versus anchor-based repair. Another study, 2020 out of Turkey, no difference in arthroscopic transosseous versus anchor-based repair. We've got long-term outcomes for these techniques, 12 to 18 years. Herbert Resch's data written up, mean ASES of exactly what I found, 92, very high, very low pain and stiffness rate. Long-term results are good. And this paper, which is a 20-year follow-up, and you're not going to find that, I don't believe, with any anchor papers, that degree of follow-up, massive rotator cuff tears. This is a who's who of shoulder surgeons, Christian Gerber, Gilles Vauche, Philippe Collin. If you read this paper, these are transosseous repairs that we have 20-year follow-up with 10% reoperation and only 2% needing reverse. So the outcomes are really not in question here. I'll move on to some technical considerations, and here's how we do it. We're going to clean the bursa out here arthroscopically. This is the device we use. It's reusable. We have a small 8mm portal. We go in an inverted fashion and pop through the subdeltoid fascia. We're going to rotate up into the 2.9mm hole that we previously made with an awl. There's no drilling or removing of bone. It's all compacting of bone. We're going to rotate down where the solid bone is, and the assistant will introduce the awl. You can see I could let go there. It's quite stable. And that's how long it takes to make a tunnel. So there's our passing suture into which we can pull as many sutures as we want. We're going to manage the passing suture out of the superior medial portal, and we're going to pull through 3 sutures, which is a triplet. And this is the functional moiety of rotator cuff repair. It's a good balance of strength and speed. We're going to fix the suture statically to the Coban and dynamically to the drape above with these little suture clips. They're different colors, so we manage the suture topographically. What's happening outside the body is happening inside the body so that we know where our sutures are. This is what it looks like internally, very similar to anchors. Now we're going to place our cannula such that the suture tails are outside of the cannula, and this keeps the operative site organized. The repair can now proceed as usual per the surgeon's desires for passing sutures. With this true transosseous hybrid technique, we're going to tie a lot of these knots outside the body. Some surgeons have had concerns about tying knots. I think we should be able to tie knots if we're surgeons. But we're going to tie these extracorporeally, and that's a little bit easier. And then we'll manage the tails superiormedially. Next, we're going to tie the simple sutures. I tie a sliding locking knot low and lateral, so it's not on top of the cuff. This is an SMC knot. And this makes the vertical limbs of the box. Interestingly, you can move the knot where it needs to be, so that you can't do this with anchors. We can put the knot where it's best for maximizing surface area compression. And then we'll secure these with knots. Here we're making the X of the X box, posterior superior limb to the anterior inferior limb. And we're going to tie these outside of the cannula as well. And that will essentially complete a transosseous repair. We could cut all of these sutures. Here we're going to reduce a dog ear just because we can. And you can put these sutures where you can do things like dog ear reduction easier than anchors, in my opinion. Here we're essentially done. We could stop there if we wanted to, but it's just getting fun. We're going to go ahead and do the transosseous, true transosseous hybrid. So we leave our tails long, and we're going to bring those down and secure them for extra backup fixation of the cortex and a second chance at knotless tensioning of the construct. And that's what it looks like inside. At the end, final construct, 5 fixation points with 1 anchor and excellent anatomic intra-articular reproduction. The outcomes have been excellent and significant pain reduction compared to anchors. This is a level 1 study out of Italy showing less pain. And I believe this is very important in modern cuff, as we have opioid-free, opioid-sparing techniques within striking distance here with this. Why does this happen? I'm not sure. I don't know. But our theory is that it has to do with increased intraosseous pressure. When you put an anchor in a bone, it causes fracture physiology and increases pressure, and which causes bone marrow edema, which can last for 6 months. When you make a tunnel in a bone, you decrease the pressure and the pain is much less, much quicker. I will mention also biceps tenodesis is another focal point. You see in the top right and left, there's many biceps ways of stitching the biceps. This is a true transosseous technique with 3 tunnels, 6 fixation points there, 7 with an anchor, and then 4 more for the biceps. So that's 11 fixation points. And I'd be hard pressed to do a repair with 11 anchors. Here's just an example of what can be done as well with advanced techniques. This is a long head of biceps, superior capsular reconstruction using transosseous and 2 lateral row anchors. There's the biceps tenodiced anteriorly. And the tensioning of these grafts is actually easier with transosseous constructs because you can pull them directly in. You don't have to measure things and be correct with the measurement. You could just pull them into tunnels and pop them into a biologically active bone marrow. Finally, I'd like to address factors affecting readoption. If this technique is the gold standard, it's been around forever. We've sort of lost sight of it due mostly to industry factors and arthroscopy technology coming along. But the things that we talk about in meetings and safety, efficacy, theoretical considerations aren't really what moves the needle. What tends to move the needle are more psychological and emotional factors like training, mentors, risk tolerance, health system, incentives, payer mix, ease of use, etc. So I want to thank you guys for inviting me to share this passion with you. And with that, I'll turn it back over to my colleagues.
Thank you, Brett, for this interesting presentation. Let's move on with Nuno's lecture.
So hello, everyone. Manos, thank you for the invitation. It's a real pleasure to be here. We know each other for a long time. Unfortunately, this time the COVID doesn't allow us to be present in Athens, but hopefully we'll be able to do that soon. So I'm Nuno Gomes. I'm from Portugal. I work in Porto. In the military hospital, and I'm going to share some thoughts on anchors that we have available today for this purpose, the repair of rotator cuff tears. So why do we watch so many changes and evolutions in anchor types and profiles today? We all know from our experience that they're not free from complications, and therefore the need for evolutions. We've been all of us have bumped into these kind of cases like this one with metallic anchors that we've been using for a long time, which later on led to a shift from metallic to bioabsorbable anchors with an equal pull-out strength and a lower complication rate. But even these, they're not free from complications. There are plenty of reports of breakage, chondrolysis, osteolysis, and synovitis after using them due to this inflammatory response that accompanies the degradation of these bioabsorbable anchors. So lots of reports on these kind of reactions like chondrolysis and arthropathy. So you can easily find these complications in literature. Plenty of reviews state that state the overall efficacy of these anchors and safety as well, but these complications are not that difficult to find. And that's why when some years ago, the bioengineers came up with this brilliant idea, and those were the soft anchors. I'm pretty sure most of you are familiar with them. Those are anchors just made of sutures, so no rigid bodies, no rigid anchors in these options. The way they're placed, as you would know, you have to pre-drill a smaller drill hole, so you don't have to make a large drill hole to place the anchors, and then you just punch in the anchor and deploy it and put it under the cortical bone and stuck it under the cortical bone just by gently pulling on the anchor. Which advantages come along with these anchors? They're pretty obvious. The drill hole is much smaller, so it reduces the removal of bone. So there's a lower risk of anchor instability because it just sits under the cortex. So it doesn't run risk of being loose inside an osteoporotic bone, for instance. And there's more room for multiple anchors in case of need. Likewise, since it's not a rigid anchor, there are no rigid loose bodies floating around in case they pull out, for instance, so in case of that kind of complication. In theory, it allows blood to the repair site because just a drill hole, and it makes it easier to go for revision. So in a way, it's kind of going back to basics when transosseous suture-only repairs were performed. And even when compared to other anchors, they perform very well. And these are unbiased studies stating that the strength is equal or greater than some of the anchors 2 or 3 times larger in the market that are available in the market with a high pull-out strength. And that's why when I first got acquainted with these soft anchors, I thought to myself, why would I use one of these that you can see underneath when I can do exactly the same with all this much? Other reports, recent reports, state what we all know. In case of pull-out, for instance, there's significantly smaller cortical defect and bone damage when using these soft anchors. Likewise, these anchors usually fail by suture breaking and not pull-out, so they're strong anchors. This is a case of mine from some years ago. As you can see, it doesn't look nice. These metallic anchors pulled out of their location inside the bone. So as you can see, the damage is quite large. So the next step, as soon as I noticed it was happening, and this was intraoperatively, I had to take them out and solve the problem. Now you must be wondering what happened here, and I'm going to show you. This was a kind of a suture bridge construct, and the metallic anchors were placed in the medial row, as you can see. Now, one means of doing this technique is placing those medial row anchors and then fixing the sutures coming from the medial row with the knotless anchor in the lateral row, like so, as you can see in step 2. Now, what happened in this case, in this particular case, was that my assistant was grabbing the sutures that she was supposed to hold them tightly, and I wasn't paying attention, so it was my mistake, and she kept on pulling them and tensioning them. So as I was punching in the lateral row anchor, the medial row anchor pulled out, as you can see in step 3. So this was the problem. Now, what can newer anchors offer us to prevent this kind of complications? First of all, if I was using a soft anchor in the medial row, although I could have, I might have had the pullout as well, the destruction wouldn't be so massive. And secondly, by using a knotless anchor for the lateral row fixation, it would be advisable and preferable to use an anchor that allows you to estimate the tension. And this anchor I was using by then wouldn't allow it. So it's tricky to estimate the proper tension, and these kind of complications can happen, but not today, I would say. Another concern around using soft anchors is the formation of cysts. Now, that is a no. There is no cyst formation, as these authors have shown. There's a very small rim of fluid that was present in around 10% of the anchors they used, and this was a prospective study studied with the MRI after 10 months. And they found in the remaining 90% of the cases of the anchors a high signal on T2 around the anchor. So it's just fibrous scar tissue that it's pointed with a red arrow, just the same you would see around an ACL repair around the graft. So it's no big deal, and it's not really a cyst. And there are some authors. There's a Belgian group from my friend Leclerc that did the same study after using soft anchors in the glenoid labrum and the glenoid rim. And their findings were exactly the same. There is no cyst formation. You can see them at the MRI after a few months, but no big deal. So the question is, which kind of construct is the best? And I would agree completely what just Brett said. It's the fixation points, the amount of fixation points that would really matter, not exactly whether you use 1 row, 2 rows. That would be some other discussion. So this nice report, this systematic review that was out a couple of years ago, based on mainly on biomechanical studies, found out that it's the number of sutures, suture limbs, and mattress stitches that are stronger predictors of strength, much more than the construct type, whether you do a transosseous fixation, transosseous equivalent, single or double row. So their conclusion was you have to balance and find the best balance between enough strength and good strength of construct and the risk of having a type 2 failure. As Brett stated, this is devastating complication, as you can see in the picture right there. It's that rupture in the muscular tendinous junction. But what can you do, and how can you use modern anchors to try and avoid that? With some modifications of the construct, you should lower the stress on the medial row, and you can address that by using knotless, not tying the knots in the medial row the construct, and by doing so, you will diminish the risk of strangulation and necrosis on the medial row of the tendon. So less risks of rupture in the muscular-tendinous junction. So what you have available today in the market allows you to use soft anchors in the medial row, and you can use lateral row anchors like the one you can see in the video right there, which allow you to estimate the tension. So these anchors allow you to load up to 8 limbs of number 2 sutures, ultra high molecular weight polyethylene sutures, like so, and then you just pull on each of the sutures separately until you have the desired tension for the construct. So as you could see, there were no knots tied in the medial row, so there's not excessive tension in that medial row, and you have kind of a suture bridge, small tear, and it's fixed. Now, there are other means of trying to address this and use what you have available in the market. And one option is the tension band type of construct. I like this kind of fixation a lot. It's a kind of inverted matrix type of fixation. And there are several reports, not many, but there are some reports stating the efficacy of these methods, and namely this one on the left showing better clinical results, and the other one on the right showing that it's probably better a better option for small and medium tears. So what do you do here? So as you saw, it's an inverted matrix kind of fixation. So after putting the lateral row anchor, you can use a soft anchor for that purpose. You can use a suture passer like this one, or if you want to control the costs, which I do in 1 or 2 settings I work at, because I don't work just in a military hospital, I work in other settings. You can use your Spectrum if you wish, and use PDS for this passage. So you can economize a suture passer, and you also economize in the number of anchors, because by placing just anchors just in the lateral row with no anchors in the medial row, you can achieve quite satisfactory fixation. You will have not a double row, but it's a kind of fixation that allows you to put the tendon against the bone in a larger area, which is the area between the anchor in the lateral row and the point of passage of the sutures in medial row, I would say. So it's much faster, it's easier, you can use less anchors for this purpose, and it's quite appealing. I use this kind of fixation for a lot of cuff repairs. So I will just jump a little bit to the front and until you see the end result, which is, I guess, quite appealing, because you can see the construct is finalized, and the whole is. You have all this area of contact between the medial parts where the suture goes inside the tendon and the lateral row anchor. Now, other things you have available in the market today, those are tapes. These are newer. They're also made from ultra-high molecular weight polyethylene, so they're quite strong. This nice systematic review from last month shows that they're quite strong. They're quite stiff. They offer a higher contact pressure between the tendon and the bone. The tapes have a higher load to failure, so quite appealing. They provide with smaller gap formation between tendon and the bone, and also they also found in a report a 16% retear rate when compared to the 20% retear rate after using wires. But this was not clinically significant. Not clinically significant, and the figures are not significant as well. So you wouldn't really know if there's a blatant advantage by using these tapes, but these are important data. This other laboratorial study from a Portuguese group, these friends of mine, found laboratorially that, on the other hand, the tapes decrease the total contact force, the total contact pressure as well, and the peak force and pressure at tendon-bone interface, which is not necessarily bad, because the risk of strangulation and impairing the vascularity on the tendon is lower. So that should be a reason for a higher success. And passing isolatedly in an isolated fashion the tapes through the medial part of the tendon also decreases that same parameters and increases the contact area. So they would advise this kind of construct, as you can see with the yellow circle. And this is an evidence that you still have a lot to learn about the technical properties and what actually these tapes can offer. But I think that's one thing is clear. The abrasion to the tendon is low, and it's easy to understand that the pressure on each per area of tendon is lower if you use a tape, which is larger than suture. This is one example of using them. Using two tapes, they come in different colors, and using a punch-in lateral anchor, knotless anchor for fixation, and you can have a very nice and easy fixation by using these tapes. Or, on the other hand, if you're looking for a fixation, for example, in a weaker tendon in an older lady, you want to incorporate the long biceps as well. Like in this case, tapes can be a good option, because the risk of cutting through tendon with tape seems to be lower than when doing that same step with a suture. So I think having tapes in your shelf and then deciding to go for a suture or a tape is it's your call. And I think having them available is quite advantageous. So you can use a couple of tapes like so to close that V-type kind of rupture. This is another tape with another color, so easy to use, no major complication in terms of technical steps. And then after reducing the size of the tear, you can place a rigid anchor with tapes. This is a biocomposite anchor that comes double loaded with tapes that you screw in like so. These anchors, in theory, offer the advantage of biodegradation, but will hopefully incorporate the bone itself, which is one of the problems you would have with PEEK and that kind of biodegradable materials. So this is a way of using what you have available in the market. So this kind of construct, as you can see depicted in the drawing, it's a kind of two side-to-side tapes, and then finalizing with another side-to-side sutures from the anchor. And this is the end result. The rupture is completely closed. So as final messages, I believe that these new implants truly offer you a vast array of possibilities, but you have to be judicious when deciding to use one or the other. Obviously, you have to consider costs and be immune to the industry-driven pressures. But I believe that what you have available and some techniques you have available and that you can choose from allow you to make a proper repair with no exaggeration in terms of number of anchors and stuff. I believe there's a clear advantage on the usage of soft anchors that's in the literature. There is no clear evidence on using tapes, but as I said, there's clearly lower pressure on each area, on per area of tendon, so the risk of cutting through tendon is lower. So the abrasion is lower as well. So I think it's a good option. And in terms of kind of construct, there are no evidences on what's better in terms of clinical results. Thank you.
So thank you, Nuno, for the presentation. And can we see now the results of the first poll for the first question?
The first question was, which is your preferred fixation choice for a rotator cuff repair? And the 50% answered that they use suture anchors, and 20% use transosseous repair, 20% vented anchors, and knotless anchors, 10%. Can I have your short comment, Brett, about this?
It's not surprising. I think we've gotten away from transosseous techniques. Many sports programs don't even really teach anything but arthroscopy anymore. And so, yeah, I think 20% is a good start. But I think with some of the cost pressures and unlimited fixation points and the principles of biomechanics that Nuno was referring to, I think in certain systems that could increase.
Okay.
So the main problem, I think, was that when we passed from mini open to all arthroscopic repairs, we didn't have a system that we could pass transosseous sutures in a predictable way. And this was the main problem. I think that the main pressure to abandon the transosseous repairs. And then we saw again the transosseous repair when we had the transosseous equivalent with the double row anchors, increasing the cost of course. And I think that as we come in contact with systems that are more predictable and in passing the sutures, the transosseous sutures, they are going to be again back in our armamentarium because I think they give many advantages. Advantages of strength, multiple fixation points, as Brett said, the idea, and lower cost, and also a biologic advantage of the bone holes that we produce, allowing for growth factors from the bone marrow to enter the subacromial space. And I would like to ask you, Brett, how you manage the tension when you do a transosseous repair, because my main problem with double row fixations was that when I was performing single row repairs, I knew exactly where the tendon would come. It would come to where my row of anchors was, so I could check the tension of the repair very well. When I was performing double row repairs, then I started performing double row repairs. This was not so easy because the tendon was coming over the tuberosity, and if you had an elastic tendon of good quality, this was not a problem. But if you had bad quality tendon, the problem was that with double row you were over tensing the repair, and this was my problem, and this produced, I think, increased pain and a probability of type 2 failure after that. And when I started again now doing transosseous repair with the same system, it's available in Greece and we can use it, the system you use. The problem was again how to check the tension of the transosseous repair now. So can you comment?
I believe the question was about tensioning of a transosseous repair. And I think you mentioned, with transosseous equivalent, if you're hammering a mallet, there's no tensioning there. You're far exceeding the physiologic tensioning. I will assess the length and the length tension relationship of the musculotendinous unit simply by pulling on it. to my knowledge, we do not have quantifiable, objectively verifiable ways of measuring the elasticity of the tendon, number one, the quality of the bone, number two. So what I do is put the sutures in and use the fingers. And it's just like when you're doing a labral repair, you can feel when the tension approaches, when the tension gets on your fingers, then you know to stop. And the beauty of the transosseous cerclage effect is that it brings the tendon down anatomically. It won't over reduce. It cerclages the tendon down anatomically. So I think that if you tie the knot, as hard as you can tie it with your fingers, it's not going to be supra-physiologically tension, if that makes sense.
Okay.
Before continuing the discussion, let's see the second poll question, which is, what is your preference for enhancing the healing process after a rotator cuff repair? And the options are use of vented anchors, perform microfractures, additional use of PRPs or stem cells, additional use of grafts, use of transosseous techniques, or none of the above. So take your time and answer this question. Nuno, do you use some additional techniques for biological enhancement?
Microfractures all the time. That's the cheapest you have available. But that brings me to another question that I think is suitable for Brett as well. Well, I would like to start with one comment, and it's needless to say that I think this transosseous technique you just presented is brilliant. So I think it's really good. We have this available in the market. I haven't tried it, but I think it's quite ingenious and it's good we have that available. And conceptually, it makes a lot of sense. But there are some concerns that you probably had as well. And I'm going to start with this, biological enhancement. One of the enhancements that is today on discussion and developed, and I think, I know it's available in the market by a company, is putting the bursa, the excised bursa, back inside the subacromial space. Do you feel the need to go for a more extensive bursectomy to be able to go down in the bursal pouch to be able to place these transosseous sutures? Because it seems that the bursectomy has to be larger, more extensive to be able to perform this technique. And in a way, you're getting rid of some bursa that's desirable to keep in the bursal space. Do you have any comments on that?
So I had some lag and some static, but I think the question was about bursa and the role of bursa in the healing of the tendon biologically.
Yes, correct. Because I have the feeling that you need a more extensive bursectomy to be able to go more inferiorly to be able to perform the transosseous sutures.
Right. So obviously there's stem cells in the bursa, and that recent research has shown that there's also totipotent stem cells, in the bone marrow. And so the first thing I would say is that typically I leave the medial bursa. In that video, I cleaned out a lot of bursa just for clarity of the video, but you really don't have to do that. The beauty of the intraosseous retrieving device that I use is that you really don't have to see to make a tunnel. So if you can if it's in the bone, you can create the tunnel, and you don't really have to see the suture going in, and you can go back and find it later. You guys were spinning there. I don't know if you heard that. Did you hear what I was saying?
We hear you very, very clear, Brett.
Yeah.
Okay. So you don't have to, but in the beginning of learning these techniques, I would recommend cleaning it out just so you don't have trouble finding the sutures. I would also say that's a great point. And one of the things that really interested me about transosseous was the ability to put scaffolds or tapes inside a biologically active red marrow medium with totipotent cell lines that then have perfect access to the healing zone. And this is why microfracture is so effective and has been shown to be the only thing that really is effective at increasing healing clinically so far, besides bone marrow, which of course you're accessing. And occasionally will do BMAC, augments as well. But, Mazaka has shown that you can harvest BMAC from the marrow. It's an option. It's not as good as the iliac crest, but it's a reasonable option. You can also chop up the bursa and put it back in the site. Some people are looking at. So yeah, I'm not as excited about maintaining the lateral bursa, but I will try to maintain the medial bursa so it can crawl back over the tendon.
Have you had any problems with suture cut through bone?
Sorry, I missed that.
Have you had any problems with the suture cutting through bone? Because these transosseous techniques, if I'm not mistaken, I think it was Pascal Boileau that presented using these buttons to prevent the cutting through the bone in the lateral side of the humeral head. Have you ever used those buttons for prevention of cutting through bone, or?
Yeah, I believe Gerber was doing that, and it's shown to increase pullout by
him, I don't know.
2x, 2 times the strength. Yeah, so obviously this is probably the most common concern. There's several things to mention. So what we did with this device was we don't use any drills. We don't remove any bone, and we make very small diameter poke holes where the tunnels are compacted, so they're theoretically stronger, number one. Number two, in my practice, there has been, we're fixing younger, smaller tears. And since the reverse arthroplasty has been around, the 85-year-old irreparable tear with super soft bone gets a reverse now. So that demographic sort of has gone away. And the soft bone happens really after about 75, if you look at the nomograms. So there's a lot of cuff patients between 40 and 75 that really don't have a lot of cutout, maybe one a year. And if that happens, if an anchor pulls out, it's catastrophic, as you showed. If a suture cuts through, you might lose fixation, but it's not going to cause a problem. And in fact, a bailout is to tunnel through a bone defect and use a low lateral anchor down in the diaphysis. Like that's a common bailout, I use. But I've used tapes, buttons, knotless anchors, commercially available. I've used retro buttons or endo buttons endosteally. So it's really dealer's choice in terms of the amount of techniques you want to use to augment a cortical surface. Anchors aren't the only way. There's screws, there's tapes, there's buttons, there's plates, and there's a lot of different options there. The sky's the limit, really.
Perfect.
When we were tying the sutures, tying the knots, we had sometimes the sutures cutting 1 or 2 millimeters in the bone laterally, but then it stopped there and it would not go on. And they give a sense of very strong fixation. And also you can use as many sutures as you like and as many points of fixation as you like. You can do a Mason Allen, you can do anything you like. It's the same with the anchors, but you can do it without anchors, and this is the idea. I think that we strive to have the same results: less metal near the joint, less destruction of bone, which is very important also. We used absorbable anchors in the greater tuberosity, and we had some catastrophic holes there. Now there are the anchors, the peak anchors, the anchors that are transforming to bone, and also soft anchors that needs much less smaller holes, and they do much less destruction in the bone. And the interesting concept is that it's the same problem trying to find solutions. And now we have many solutions to have a strong fixation to the bone, a strong fixation to the tendon, and a strong biologic enhancement, augmentation of the repair through holes, in either through mini fractures or the vented anchors that we have now available, or the transosseous repairs. It's an amazing concept. I hope that next year we are going to have this. We'll have you, Brett, in Athens, and have the opportunity to have live surgeries doing this transosseous repairs, and live our fantasy to find ways to manage sutures and pass the sutures and make combinations of sutures in order to have a stronger fixation of the tendon to the suture tendon fixation to be stronger, because this is another problem, the fixation of the cutout of the tendon from the sutures, which is, I think, the major way of failure now. The most common way of failure of a repair is not through anchors pull out or through cutting the bone, but it's through the tendon not healing and then cutting the tendon through the sutures.
Yes, and that's an advantage of transosseous that has been seen, especially with simple sutures. Like Nuno showed that when it fails in a type 1 mechanism where the tendon pulls off and you still have tendon to repair, whereas the medial anchors are essentially too stiff and they strangulate the tissue and then transect the tissue. And so the revisability of simple suture constructs and the effect on vascularity, I think, is important, for revision surgeons especially. Hey, I had a question for Nuno. How is the pullout of the soft anchors in bone? Have you noticed that to be a problem, especially laterally? Do you use soft anchors laterally?
Yes. Every time I do these tension band types of fixation, I place them laterally. I haven't had that issue that much. It happened a couple of times, a few times, but I would say that probably the main reason for that happening is not necessarily weak bone or osteoporotic bone, but the fact that when punching in the anchor, the guide damaged the bone a little bit. Obviously, if the bone is weaker, that can happen. But the truth is, when looking back at the experience I had with rigid anchors, and those were titanium anchors, because I shifted from titanium to soft anchors. I was never really a fan of PEEK and stuff like that. They were trendy some years ago, but I always stuck to the titanium. So I shifted from titanium and soft anchors, and that also happens with the titanium. And I have the feeling that it happened a lot more. It was more common to have that problem of pullouts of the anchors with titanium than with soft anchors. So as long as you preserve the integrity of the cortical bone, you should be okay, even with osteoporotic bone. Obviously, after a while, and once you get used and acquainted with the means of fixation and these anchors, you find some tricks and ways of avoiding that problem. And if it's an older lady with a weaker bone, I just perforate the cortical bone, so I don't get down to the laser marks, so I don't perforate the whole length of the drill. And that will allow you to have more cancellous bone underneath. So as you punch in the anchor, it goes all the way down. And then when gently pulling it up, the anchor, as it deploys and opens, it brings all the cancellous bone all the way until the cortical bone. So I don't think that's a major problem. It's a problem that can happen the same way it can happen with rigid anchors, and with the same way you can, or probably with the same rate of appearance as you would have with the transosseous and cutting through bone. So it's probably the same rate of complication, I would say. It's not a major problem, the pull out of the bone.
Yeah, it's interesting. I view soft anchors topologically as, it's a suture with a pre-tied knot, whereas transosseously, it's a suture put through the bone and then we tie the knot. But they're based.
What do you mean pre-tied knot?
A soft anchor is a suture where the company has tied a large knot on the end, and that's what fixes it in the bone, or a pledget, where they just have a chunk of suture on the end. And
okay,
so, it's essentially, from an implant standpoint, it's very similar. It's just that we're tying the knots afterwards, and we're getting double the efficiency because we have two fixation points. But what brought this up was Manos's comment about the plastic deformation as you're tying the knot of a few millimeters. And one of the tricks I do with that is to put the knot stack into the tunnel. And then for the other sutures, I tie against that knot stack. And you can push the knots down into the tunnel, and it acts like the suture implant that you use, where you have a stack of high molecular weight polyethylene that acts like a little pledget inside the tunnel, if that makes sense.
Yes, this is something that I noticed, it, that when you start using transosseous or sutures, you change the way you think about the knots. When we do a normal repair, we put the knot on the tendon, and we put also the pusher, the knot pusher on the limb of the suture that goes on the tendon. But when we do transosseous, we put the knot pusher on the limb that comes from the lateral hole, so that the knot goes straight to the hole, and the tension is to the suture that comes from the bone, not from the tendon in the beginning. So you manage to have a strong fixation of the knot into the entry of the lateral tunnel.
Mm-hmm.
Looking at our participants, I would like to say hello to Mattheos Savidis and Periklis Papadopoulos from Thessaloniki, and to Alexandros Kidrakos from Rhodes, and Mike Hunters from Larissa. I think their questions have already answered. And Brett, you said that you have less pain with this technique. How do you believe? Why you believe this happens? Because extensive brucectomy, as Nuno said, is related with more adhesions and sometimes with the slow recovery. What's your experience for this?
The stiffness and pain have been much reduced with transosseous techniques. I was an anchor surgeon before I started doing this. I was trained on anchors like everybody else, and my physical therapists actually called me and said, "What's happened to your cuffs? They don't hurt anymore." And so the pain, which is related to stiffness, and I think the over tensioning and the bone pain are the largest effects here. I haven't noticed that bursectomy has caused, I've got some videos I could show you of, 9-month looks at post repairs, and they don't have a lot of adhesions. I've always regarded that as mostly genetic, just why does someone get a frozen shoulder? I mean, it depends on the chemical milieu of the patient's tendons and ligaments, as far as I could tell. I've done some techniques looking from inside, actually, looking from intra-articularly, and you can put the tunneler in without seeing it. That's what I was saying. You don't need to take the bursa out. You don't even have to see it. And you can pass the sutures from inside. And so if you wanted to totally stay out of the bursa and tie it laterally, you could. It just takes a little bit of technical modification.
Okay, perfect. Okay.
Yes. We don't know why some patients have more pain than others, but I think that what I see that if you repair without tension, if you repair with transosseous repairs or with vented anchors also, we had a similar result with anchors that are vented and allow for the pressure in the bone to be reduced. I have the impression that the pain of the patient is less. It's very difficult to prove this, and see, we need a lot of too many patients in order to have a statistical significant difference. But the impression is that with this type of techniques, the patient have a better initial postoperative period. The initial postoperative period is less painful, and they are becoming quicker, more active.
I think you'll see, I've heard from other surgeons that use soft anchors like Nuno that they have noted some reduced pain with soft anchors versus hard anchors. And I think it's the medial row anchor where the bone is harder. And if you put a big anchor there, that's been my impression. I don't think the lateral row anchor has a lot to do with it, but certainly smaller anchors or no anchors that don't create the fracture physiology of expanding the bone seem to be less pain. That's been my impression as well.
No, there's a question for you from the audience, from George Mazis. For the medial row, do you prefer hard anchor with tapes or soft anchors with sutures?
Hard anchors with tapes
Or soft anchors with sutures?
Soft anchors with sutures. I'm eager to see how soft anchors with tapes will work, because they've been developed. They should be out in the market soon. So I'll definitely try them once they're out, but soft anchors, not rigid anchors.
I would say also soft anchors.
I tried the rigid anchors with tapes because I wanted to use the tapes. That's all, because you don't have soft anchors with tapes available. At least I don't in the Portuguese market. Not yet, but soon they will be available.
Okay.
Yes, and I would comment also on soft anchors. All the soft anchors are not the same. They are not having all the same pull-out strength, at least in my experience. And it's good for everyone to use some type of soft anchors and see how they behave, because they are behaving different. They are not the same. And also, I would say
the means of application is different.
Yeah.
Brett, there is also a question for you. As far as the subscapularis lesion is concerned, can you repair it with transosseous device, and it is simpler or more demanding than with doing it with anchors?
Yeah, good question. That's one of my favorite procedures, actually. I showed the biceps. So it's the same portal and everything's just moved over a little bit. It's actually very easy. The bone is always hard, essentially, in the biceps groove. And I usually will tendinese the biceps simultaneously. So I just go right through the biceps. And to me, it's easier than anchors because you're passing the suture under the strap muscles is basically the hardest part. Making the tunnel is easy. You just bring the arm into forward flexion, external rotation, and the geometry fits the lesser tuberosity perfectly. But for me, it's easier because you're passing simple sutures under the strap muscles instead of mattress sutures. So it's a little bit less time for me.
Yeah.
Okay. And who is your rehabilitation protocol? Is something changed or it's the same with doing with the anchors?
Physical therapy,
Yes.
the same. I use the same. I go very slow, 6 weeks. If it's a medium or massive tear, 6 weeks. Smaller tears or combined lesions, I'll sometimes start at 4 weeks passive motion. But I worry with the low pain, the low amount of pain that most of the patients have, I really worry that they're going to go too fast and re-tear. So I'm telling them not to do anything, and they're probably doing things anyway. But in some ways, the pain may help, reduce their activity level. But I go very slow, and I don't want to redo the tear. I'd rather have a stiffer shoulder with a healed tendon and do therapy to get out of that than a re-tear of any kind.
Okay. Well, I think everyone is agreed to this.
Well, actually, I think I've been going the other way around. I've been more aggressive with the rehab lately. I give the patients self rehabilitation protocol and have them doing it. And I have the perception, but this is just perception. I don't have the exact data. I have the perception that the stiffness is lower. They have less stiffness by starting early in the post-op period, the cell rehab. Obviously, that depends on the size of the suture and how strong the fixation was. But I've become more aggressive in terms of post-op rehabilitation in the past few years.
Do you use link, Nuno?
Yes, for protection for 4 weeks. Neutral position. So with the forearm in the front of the torso. So nothing special. And I allow the patients to move freely and do passive movements with no pain.
So I had the impression that if we say to a patient, okay, don't you move your arm, if the patient is having pain, is going to follow the advice. If the patient is not having pain, is not going to follow this advice, and he will start using the arm. So what I'm doing now is I'm saying to the patient, okay, try to avoid hurting your arm. Don't do anything that hurts.
Correct.
And try to use it, but very slowly, very not abruptly, not aggressively, because otherwise you are going to have pain. And I try to follow this type of protocol because I was not anything else I was doing was not followed by the patient. I mean, if the patient is not feeling pain, he's not going to keep the arm in a brace or in an abduction pill or anything like this. If he's having pain, he's going to do it. And so I try to make the patients more comfortable and try to protect themselves by following the idea of not doing anything that it is painful. Avoid anything that is painful. But what you can do without pain, do it, because probably it's going to be okay.
Great, guys. Thank you for the great presentations and very well to the point that you had to speak. Let's see the results for the second poll. So biology, the 5% use microfractures and the 5% none from the above. Nuno, do you have some comment on this? You said you use also microfractures. Is the most popular technique?
Well, nothing to say. I think some of the other options are a bit expensive, or at least they're not cost-free. So you have to be judicious when trying to go for them. The usage of vented anchors, the ones you have available today, are made of PEEK or other bioabsorbable materials, which are slow biodegradable. So they're not my option today. Well, conceptually, they don't seduce me, so I wouldn't use them. So I think microfractures, it's the fastest, and the easiest and the cheapest you have available. So I'm happy to know that.
Perfect.
Costs are a concern, definitely. And I really liked seeing your talk, Brett, and namely the first slides, because you focused on that. But I don't resist asking you something, if you allow me. How do you feel personally about that concern in a country that's known for having the most expensive healthcare in the world, I would say, if it's not the most expensive, but probably one of the most expensive. And trying to economize on a surgery does not necessarily mean economy for the patient. You have a lot of middlemen between you and the patient, and probably the end result for the patient is not necessarily economy. What do you feel about that? If I may ask.
Great question.
It's a sensible
Very
question.
frustrating. Very frustrating. I actually practiced for a year in the NHS, so I've been on both sides of the pond there as a practicing physician. You're right. Our system is very complicated. There's a lot of third-party payers, and it sets up. There's no negative feedback for cost, which leads to exponential increase in cost to the point where the system may, break or the prices exponentially increase with no ceiling. And so for a long time, I searched for where could I find, people to care about cost. The problem is if we don't care about the cost, someone else will, and the government or an insurance company will eventually make us do things. So if we're not good stewards of cost, then we're going to lose options. That's what's going to happen. And at least where I am. Now, you guys live in systems and in countries where there's more direct to consumer trickle down of cost savings, or at least improved access to care. And in big hospital systems where I am, I don't really feel that that's the case, but I'll tell you where it is, and it's one of the biggest trends in orthopedics in the States anyway, is outpatient surgery. So all the joints are going outpatient, and outpatient surgery centers that are owned by physicians, where they're owners of the facility, that is where the cost will be recognized and driven by the user. And it saves the physician owners a lot of money. And then it can be how it should be, where the physician and the patient are actually driving the interaction instead of third parties profiting off of the interaction between the physician and the patient. But it's harder to find that. It's a great question.
Yeah. It's one of the problems that we face and we are going to face in the immediate future. And there is going to change a lot of things.
It was slow to come to us, but the trend has already started. The third-party solution has already started with or without us, and it's called bundled care. And so that value equation that I showed, we're going to be constrained, per episode, per diagnosis code. If you have a rotator cuff, they're going to pay you X, and they're not going to pay you X plus whatever the biologic cost. They're going to pay you X. And then the doctor decides, you're going to get paid X. And if you want to use more than that, you'll end up paying the patient to do the case. And this is a big barrier for biologics. The future of cuff repair is probably biologics. That's one of the reasons why bastioning Transasius because I think if we can take some of the cost off the hardware, if we can have unlimited fixation points, it raises the cost ceiling to bring in biologics, which is the new frontier. How many other anchors are you going to do? You know, I mean, we've kind of done it all at this phase. And so the bundled payment is what is happening. I think eventually that's what's going to, you know, the commercial insurers are already starting to not pay for implants anymore. So you'll see more single row repairs. You'll see more open Transasius repairs. And so my point with bringing this Transasius device is, you know, does arthroscopy matter? Does that provide any benefit, or was that just a piece of technology? So at least we can keep it arthroscopic, and we can have the benefits of arthroscopy, and then at least increase the cost ceiling for other technologies to come in, specifically biologics.
This is it's a problem for our system. However, the next episode is in May 20, and it will be on anatomic shoulder arthroplasty. Giuseppe Porcellini and Pietro Randelli will be our guests. And once again, we would like to thank you both for your presentation, for your presence. And I hope everyone enjoyed this battle.
Okay. So thank you, Nuno. Thank you, Brett. You were perfect, both of you.
You're welcome.
We enjoyed it. And I hope that our next meeting is going to be live and not virtual. And we'll see you both in Athens. Thank you for...
Very good.
Thank you, Manos.
It's been a pleasure. Thank you so much for the invitation.
Bye.
Bye.
Thank you all.
Help us improve ourselves by completing a teeny tiny questionnaire after the poll results are displayed. And thank you once again for attending. Follow BMedNet because many interesting webinars are hosted in the forthcoming period. And have a good night. Bye-bye.